bladder tumor, misdiagnosed as cancer of the cervix. This case was that of a 60-year-old Paraten who presented with a history of low abdominal mass. General examination revealed a chronically ill-looking woman who was pale. Abdominal examination revealed a heart, non-tender, immobile, and irregular mass in the suprapubic region, which was equivalent to 18 weeks of gestation. Vaginal examination revealed a hard mass in the anterior vaginal wall, but the cervix appeared healthy. Urine bag contained turbid urine. This was the report by a specialist of the abdominopelvic scan. Of interest to us are the last 3 paragraphs. Both kidneys are normally in position, size, and outline. They both show moderate hydronephrosis. No evidence of calculus. Distended urinary bladder with normal mucosal lining and wall thickness. No evidence of vesical mass or calculus. There is a huge pelvic soft tissue mass with heterogeneous ecotexture measuring 10.3 by 13.2 centimeter in diameter. No evidence of calcification. The mass appears to obliterate the urinary bladder, uterus, and adnexa from view. Conclusion was pelvic mass, quasi-cervical cancer with bilateral grade 2 hydronephrosis. Now let's look at this paragraph on the last sentence. Here, the report says distended urinary bladder with normal mucosal lining and wall thickness. No evidence of vesical mass or calculus. And the last sentence says the mass appears to obliterate the urinary bladder, uterus, and adnexae from view. So it's difficult to reconcile these 2 sentences in the same report. I repeated the scan a week later, and this was what I saw. Huge heterogeneous mass with color score of 2 and not the cine lobe of the lesion with the color floor. Again, I noticed the presence of the catheter balloon somewhere here. So I wasn't sure whether it was the mass that compressed the catheter balloon or that the catheter balloon was actually within this lesion. These were the transvaginal images. Here you can see the catheter tube in the urethra and the balloon in the bladder. So this was actually a bladder lesion and not the cervical lesion as reported. These are calcified aqueous vessels, which are normal in this age, not the triple layered endometrium. The lesion, the uterus with a color Doppler of the aqueous vessels, not fluid collection within the endometrium, fluid in the pouch of Douglas. This is the video of the same patient. Now let's look at the video together. I will withdraw the prop and reintroduce so that we go through the video together. So now withdrawing the prop, getting close to the introitus, and there we are. So I will now introduce the prop gradually so that we can do it together. So the prop going into the vagina, so you can see the catheter tube in the urethra, the lesion here, and as I introduce the prop, you can see the catheter balloon within the bladder, and shortly we shall see the cervix. So this is a cervix. So normal cervix. So this is a bladder lesion and not a cervical lesion. Again, look at the fluid in the porch of Douglas, the uterus with the calcified aquatic vessels, fluid within the endometrial cavity. So what are the learning points? The recommendation is to always perform a trans-abdominal scan with a full bladder. Where the skill is available, do a complementary trans-vaginal scan as was done for this patient. Report what you have seen and document what you have not seen. Remember the initial report we reviewed. If there's any difficulty, pass a catheter into the bladder. This will help differentiate between a bladder lesion and other pelvic lesions. When I pick this mass, I ask the patient a brief and a focused history. Any history of hematuria? He said yes. That strengthened my diagnosis of a bladder lesion rather than a cervical lesion. Thank you very much.